Welcome to 12 lead ECG part 1. This is number 1 in a series about 12 lead interpretation. I designed this with EMS providers in mind, but hopefully the material, the information will be helpful to anybody who's trying to get a handle on ECG interpretation. This first video is going to talk about why we do 12 leads in the field, when we should acquire them, and some tips and pointers on how to get a reliable 12 lead that you can make an interpretation from. How do you know who needs to go to the cath lab? We use 12 leads to provide us the evidence of a need for cath lab intervention, but it's important to remember as we go through this and as we look at the 12 lead that that's only a piece of data, a piece of evidence. What you also really need to focus on is the story. We need to get good histories. We need to get good story. We need to do comprehensive exams because those are the tools, those are the pieces of information that will help us make sure that we should be using the 12 lead to make a decision, as opposed to being lulled in or tricked into one of the, what I call imposters, those things that may look like a STEMI, but are actually being caused by something else. So we do 12 leads in the field because we're trying to definitively identify this phenomenon that you see on the screen, which is a blockage of an artery. That pathophysiology is simply that there's plaque buildup. If you're over 25 years old, you probably have some amount of plaque in your coronary arteries. And over time, as we age, that plaque gets worse. Now, a variety of things can contribute to that, as we know. But when the plaque breaks, when there's a rupture to some portion of that plaque, the body interprets that as an injury. It sends clotting factors in, and it's those clotting factors, the clot that forms to heal that plaque, that ruptured plaque, that actually obstructs a coronary artery, either partially or completely, and then leads to an infarct. Identifying that early is how we can make sure that we get someone to the right interventions to open that artery and restore perfusion, hopefully before any permanent damage is done to cardiac muscle. A few critical concepts in acute coronary syndromes to keep in mind as we're working through this is that ischemia is a warning sign. Ischemia can show up in a variety of ways on our 12 lead, often ST depression or a variety of T wave changes that I'll talk about. And if it's untreated, if it continues, it progresses on to injury. And this is where ST elevation identification comes in. It's that ST elevation that we're going to look for on our 12 lead because it's showing us proof that there's actually injury occurring to myocardial muscle. It progresses from there to infarct. Once we actually have infarcted tissue, we have death of tissue. That doesn't come back. There's no recovery for those particular tissues, although opening the artery may help surrounding tissues to survive the insult. But what tissues have actually died, we can't do anything about. Our focus in 12 lead interpretation is identifying ST elevation myocardial infarction, and it probably should be labeled ST elevation myocardial injury because that's when we really hope to catch it, is at that injury stage before that permanent damage has happened. Couple key concepts. They say time is muscle, and basically what that means is the longer that the heart muscle goes without appropriate oxygenation and nutrients being supplied, the more muscle dies. And so the quicker we can get someone to a specific intervention, that being the tools that open up the vessel and restore blood flow, then the better the outcome. And there's definitely strong evidence to show that systems of care that do this well have an impact on patient outcomes. The definitive intervention to open the artery is placement of a stent. There's a variety of other strategies, and obviously some patients need a bypass or something because this technique isn't going to be acceptable. However, this is used in a majority of patients that have a coronary artery blockage, the majority of STEMI cases, because you simply slip a wire in that has a balloon and a stent around it. The balloon is inflated, as you see in the middle picture, and then the balloon is deflated and withdrawn, and the scaffolded little structure that is called a stent keeps that artery open and maintains adequate blood flow to that area. So when do we do a 12 lead? The simple answer is we should do it early and we should do it often. Anytime we suspect a cardiac etiology with our patient, anytime we suspect there may be a possibility of infarct, we should do it. And I say we do it often because evidence of a STEMI, evidence of an infarct may not show up immediately, but it may show up as that infarct progresses and over time. It's also important that we do it before we administer nitroglycerin to these patients. So when we think about how we're treating these patients and the timing of it, that's important to consider. So here's one example of a patient I saw years ago when we first started doing 12 lead interpretation in the field, and you can see there's some pretty obvious ST elevation across the V leads. This was done at 4:06 in the morning, and we gave this patient nitro at 4:08. We did a subsequent 12 lead on the exact same patient 10 minutes after the nitroglycerin, and you see that all of the ST elevation is gone. With the evidence of that first ECG, we were able to take this patient straight to the cath lab. If we had given nitro first and then acquired our first 12 lead, we would have effectively hidden the evidence that a STEMI was occurring, and it may have delayed treatment for this patient. So when we think about assessment and treatment of our cardiac patients, there's a variety of things that we're trying to do: history, vital signs, getting oxygen saturation, doing a 12 lead. The treatments, oxygen, aspirin, nitroglycerin, IV access, morphine, all of these make sense. The key thing is we don't do these in a linear fashion. We're doing multiple things at the same time with these patients, all of which works well. We just need to make sure that we do the 12 lead before we do the nitroglycerin, so we don't hide the evidence of a STEMI before we've actually determined that that's what's going on. So when we look at our standard STEMI protocols, our standard approach to 12 lead, we're looking at a chest pain or cardiac equivalent complaint. We're doing our assessment and general treatment like I just outlined. We're gathering 12 lead hopefully early, and we're trying to put our patient into one of these three categories. If they have ST elevation, and we'll talk about the specific details in a minute, or a new onset of a left bundle branch block, which is a little trickier to diagnose in the field, then those patients are candidates for reperfusion, whether that's a cath lab or fibrinolytics. If, on the other hand, they have ST depression, that's an important clue as well. On the far right, we have non-diagnostic, meaning my 12 lead is not giving me any proof of anything. That does not mean that they're not having an MI. It simply means that we don't have proof on our current ECG of that. But we need to pay attention to the main focus is their ST elevation, and also ST depression or T-wave changes, which can be indicative, can be clues that the patient is working their way towards a STEMI. Some more basic concepts: pain equals injury. Our goal is to make sure our patients are pain-free. Time is muscle, we already said that. And hospitals traditionally have tracked door-to-balloon times or door-to-drug times. In other words, from the time the patient gets there, how long does it take before a definitive intervention is done? For EMS, we've gotten much better at this, and what we really need to be tracking is first contact to reperfusion. So how much time from our first contact with that patient does it take before they are being reperfused in an effective manner? Time is the issue. That's what we're trying to do, is minimize the time between first identifying that there's a problem and getting them to definitive intervention. So a couple things about that timeline. Onset. We don't have a lot of, other than through public education, there's not a lot we can do to determine the time from when they start having pain until 911 is called. EMS response, in most systems, we can't control how long it takes us to get there. Treatment and transport. We have some impact on how much time we spend on scene. Often we don't have much impact on the amount of transport time it's going to be involved getting them to a definitive facility. And then hospital time. Now, if we look at this a little further, hospital time is broken down a little more because the hospital isn't ready to take these patients straight for an intervention. So the first chunk of time at any hospital is going to be prep time. Whether that's getting a cath lab ready, bringing in the right personnel, putting some things in motion before the actual intervention can take place. So again, we can't change onset, we can't change response. We can have some variables when it comes to EMS treatment and transport. And if we have a long transport, if we don't do anything different in our approach, then obviously that intervention is going to be pushed out even later. But we actually can change this, because what we can do is notify early. If we notify early, the hospital can start that prep before we get there, meaning that the intervention is going to be done earlier rather than later. We can even move that timeline further. If we notify even earlier, it's possible that the hospital has enough time to get the equipment, the room, the personnel in place, so the minute we hit the facility, they're able to do an intervention, and even with a longer transport, potentially shorten the time to treatment. The next thing I want to mention is how you make sure that your 12 lead that you've just captured is going to be a clean, clear 12 lead that you can make decisions on. Couple of things. Skin prep. These things that I'm going to mention right now are so often overlooked, and they aren't always necessary. Sometimes you can go to good tracing without these steps, but making this a part of your regular practice will improve the chances that you get a good, clean 12 lead. If you have hair on the chest, you have to get the hair out of the way. Electrodes that are sort of hovering over the chest don't do a good job of gathering electrical signals. Cleaning the skin is the one that's also overlooked. It's much simpler and quicker than shaving. If you take a 4x4 or any gauze pad and just rub the area vigorously before you put on your electrode, it's going to stick better, it's going to adhere better, it removes oils that can interfere with the signal, it's going to help you get a cleaner tracing. The other is to keep in mind the electrodes themselves. They should not be stored out of a package for any length of time because they dry out. And keep in mind the part that dries out is that little space in the center. There's a little gel contact. That gel is what allows electricity to be conducted effectively so that we can see a clean tracing. The area around that gel is adhesive, and most of our electrodes these days will stick really well even after the electrode has been very dried out. So you may have good adhesion, but just because it sticks to the patient's chest doesn't mean that you're going to get a good tracing. And if it won't stick at all, then obviously that gets even more challenging. Keep in mind patient movement, cable movement, and vehicle movement. You notice in this picture the patient is holding the cables in his hand. You can clip them to their clothing, clip them to a seat belt. What you don't want is the cables hanging with the weight of the cable pulling on the end of those little electrode snaps, because that will also interfere with the quality of your signal. This is one that gets people worked up sometimes, and I've talked to a number of paramedics in the field who swear this doesn't make any difference. But I absolutely believe it does, and the manufacturers of all of these devices say that it does, that limb leads are designed to go on the limbs. Now, if you are simply monitoring your patient for the purpose of gathering a rhythm interpretation or keeping an eye on their heart rate, you can basically put the leads anywhere on the patient's body and get a tracing that will work for that purpose. But if we're going to do 12 lead, and especially if we're going to use the machine's diagnostic capability, it's important that the limb leads be on the limb machine thinks you have placed those leads. You can either put them at the wrists and the ankles. If that creates too much movement or artifact, you can also move them up and have them near more proximal on the extremities, but it should be balanced between legs and arms, because again, the machine is going to interpret that, and it will make a difference in some patients. On many patients, it may not make any difference at all if you move those to the torso, but when it comes to things like axis determination, it absolutely makes a difference. Chest leads. I'm sure everybody watching this is probably familiar, but just quick review. V1 and V2 go in the fourth intercostal space on either side of the sternum. V4 goes in the next intercostal space in that mid-clavicular line. V6 goes right in the axillary line, in line with V4. And V5 and V3 split the difference between those other leads. That gets a nice wraparound view of the heart. Well, what about a patient with big boobs? We obviously have patients where the anatomy of our patient is going to make it more challenging to make those placements look like they do in some of those pictures. Whether that's a man or a woman, the challenge is getting it placed appropriately. And the question comes up, do we go over the top of the breast? Do we go under the breast? And the answer is yes. Either one can work. What's important is that you think about the underlying anatomy and align your electrodes in a way that they're not being angled, they're not being skewed in a different direction, and that essentially you're still wrapping the electrodes around where you know the heart is so that you're going to get a good representation of the electrical movement in that horizontal plane. So this comes back to the idea of artifact. And in this example, this is a patient who's hooked up to a 12 lead and the cables are dangling. In other words, the cables are all plugged up, all the electrodes are snapped on, all the wires are snapped onto the electrodes rather, and the cable is hanging with some weight on it. The only difference between this tracing and the next one I took was we picked up the cable, kind of like I showed in that picture, and made sure there was no tension on it. The first one, any movement, breathing, anything creates a baseline that is really not helpful for interpretation. This is why we have patients hold still, lay perfectly still for the 12 to 15 seconds while we're acquiring that 12 lead tracing. Couple things on the monitoring themselves. 4 lead versus 12 lead. Obviously, we're using more wires. We've got 6 more wires. We have 10 electrodes hooked up to the patient. People that are new to this are confused by the fact that it's called a 12 lead, but we have 10 wires. That's because we can get 12 distinct views using those 10 wires. But in addition to more wires and more views, the other thing that's important to recognize is that with most machines, with most ECG interpretation machines, there's a difference between monitor quality and 12 lead diagnostic quality. So on many of these machines, when you're in the monitoring mode, what you see is filtered. So like this example is trying to show, the machine is designed to filter out extra stuff. That's why your patient can be talking, they can be moving, and you can still see their underlying rhythm. You can still make out the QRS complex. You can still make a rhythm interpretation because a lot of things are filtered out. When you switch that machine into a 12-lead mode and do that diagnostic quality, this is where it becomes important that your patient lay still because the filters are removed. That's great in terms of seeing the ST segment, seeing the ECG baseline, picking up on an implanted pacemaker that may not show up in a single lead view. The downside is you also get more 60 cycle interference, more skeletal muscle movement, more other outside interference is going to show up. And that's why we pick up more artifact and also more detail when we go into that 12-lead diagnostic quality. When you do your 12-lead, after you've acquired it, there's a few things you can look for just to make sure that you've done this appropriately. Number one is you look in AVR, that view from the right, so to speak, and if it's upright, you most likely have reversed your leads. You want to look for one complete cardiac cycle in each lead. You want to look for a consistent baseline, and you want to look for a lack of artifact. And I'll show you examples of each one of these. So in this example, you look at AVR, that view from the right, as if you had your camera positioned at the right shoulder, and all the electrical activity should be moving away from the camera, meaning that the majority of your QRS should be below the baseline, like you see here. That means your leads are likely hooked up properly. The next thing I'm looking for is each complex. I'm going to look across left to right. In each of the 4 segments, I want at least one complex that I can see the entire cardiac cycle, P-wave, QRST, because then I have a clean view in each of the 12 leads that I need to look at. And I also want to look for that baseline. Now, real patients have some anatomic, some physiologic variability, just like you see here. That baseline may move up and down a little bit, and that's okay. We can work with that. It's not always going to be as perfectly flat as you see in machine-generated or textbook-produced rhythms, but we want it close to a consistent baseline to improve, and we don't want a lot of artifact. We don't want a lot of extra electrical activity or waving baseline or things like that. It's going to make it harder for us to read. That's the basics. The very first part of this is short, sweet. Part 2 is going to cover what evidence the 12-lead actually shows us and what we should be looking for.